Good afternoon, and I'd like to welcome you all to today's event. It's the third webinar in the ESR Connect series on COVID-19. And today's episode is co-sponsored by the International Atomic Energy Agency. And I'm delighted to welcome to today's broadcast Dr. May Abdel-Wahab, who is the Director of the Division of Human Health of the IAEA. And Dr. Abdel-Wahab is going to address us initially, and then we move on with the second part of today's program. So Dr. Abdel-Wahab, thank you for joining us.
Thank you very much for the invitation. Colleagues, today we're all dealing with COVID-19 pandemic, which contributes and continues to spread globally. We have 1,400,000 cases and 80,000 deaths registered in more than 183 countries and territories, and the numbers are increasing every day. So this places huge demands on the medical system of countries, affecting all fields of medicine, including radiology. And many radiology centers are already confronted with the realities of the COVID-19 pandemic, with unforeseen situations in hospitals, with mass spread of infection, dramatically increased patient admission, overloading of clinics, shortage of staff and equipment, and changes in radiology practice were really important. So many of these centers are facing these challenging decisions, and they've reached out to the IAEA for recommendations. So we work together with professional societies such as this one worldwide to facilitate best practices and achieve consensus on practical considerations for protection of the patient, staff, and public. Changes to radiology practice, ethical, legal protection, and issues in radiology are extremely important. I would like to take this opportunity to express sincere gratitude to all our colleagues who continue to be at the forefront under difficult conditions, exposing themselves even to high risk of infection. So thank you for coming today, and I would like to go next, please, and touch on the subject. Next, please. Please move the slide. Okay, thank you. So basically, as we remember, in December was the first time that the WHO was informed of pneumonia of unknown cause, and then a new type of coronavirus was isolated. After that, we had a public health emergency of international concern announced in February, and in March already we started thinking about, or the WHO announced that this was a pandemic. Quite quick moving. Next, please. Please move the slide. Thank you. So we know, of course, that RT-PCR is a main diagnosis, but there are many issues like negative initial testing, and in many countries, lack of widespread access to testing capability. The use of X-rays has been widely used and is an integral part, and also CTs, but I'll let my colleagues discuss this. Next, please. So on our Human Health Campus, we are keeping track using data from WHO and Johns Hopkins. And as you can see, there's widespread involvement. We also have a listing of countries that are being supported through IAEA assistance as well. And if we move to the next slide and look at Europe and other areas. Okay, so this is, okay, there we go. That's better. So then we could see that there is support as well for Europe, and especially in Eastern Europe through the IAEA. We can see the curves showing how this is really an exponential increase. This is available again at the Human Health campus of the IAEA. Please, next, please. So what kind of assistance can we offer? We're supporting almost 105 countries in different ways. About 90 countries are requesting specific equipment and specific supplies. We have already supported about 40 countries for the first round and 20 countries for the second round using RT-PCR equipment, which is extremely important, obviously, biosafety cabinets, centrifuges, other kits and consumables and detection kits, all to be able to support the diagnosis, but also some portable X-ray equipment, personal protective equipment. We have webinars that we have almost weekly, and guidance documents that are extremely important to support our colleagues around the world. Next, please. If we look at operational guidance, there are some guidelines of what to do. Some of them are very general, but in our guidance document, we will have specifics under each one. And then we could also see that there are essential considerations that will never change, whether things related to the patient, things related to medical staff, or the environment. Next, please. And finally, I just want to bring up that there are physician, patient, and system factors that we should keep in mind as well. As we look at the different levels of our brain and how people respond, we find that the cortex is our usual way, but as we get into a situation such as the pandemic or other such situations, we have other fight and flight responses and that. So we should keep in mind what patients are bringing to the table, what physicians themselves are bringing to the table, and things related to the system. And all of these work together to make us either able to achieve what we need to achieve, or they could be hurdles and we end up in difficult situations. So with that, I just wish you all the best of luck, and thank you again for everything. Next, please.
Thank you very much, Dr. Abdel-Wahab. That was very interesting, and we're delighted to have you join us today and to have you, the IAEA, co-sponsor today's webinar. We're certainly very happy to work jointly with your organization to assist countries and radiology departments and radiologists in any way we can through this crisis. Now, to move on to the second part of today's webinar, one of the activities that's been undertaken by the ESR has been the writing of a short paper giving practical advice to radiologists and radiology departments about managing patients with COVID infection, and to departments about managing their resources during this period. And we've written that paper quite quickly with experts from the European Society of Thoracic Imaging. That paper will be published in the very near future in European Radiology, but it's already available on the ESR website. And our first speaker this evening, Professor Marie-Pierre Crevel, is going to tell us a little bit about that paper as the first author of that paper.
Yes, thank you, Adrian. So good afternoon, everybody. So on the initiative of ESR, we indeed prepared an advice paper about COVID imaging. Next slide, please. And it was a collaborative work between different members of the European Society of Thoracic Imaging. I have the next slide, please. The next one. So you can see these colleagues, Naga Parkar, Helmut Prosch, Mario Silva, Nicolas Verzelati, two Italian colleagues who where we are from Parma, which is a very high epidemic area. So this is the different question we try to answer. What are the main city features of COVID disease? We presented some typical findings. Who should benefit from city and what information can be obtained? What protective measures should be taken for the staff? It is very important to protect our staff. How should the imaging department organize to face the epidemic? And it's going to be the main topic of this session today. And we also proposed a structured report highlighting the main city findings to report and how we can quantify the disease extent on cities. So all these informations you can obtain then by going on the ESR homepage, and there you can download our paper.
So thank you very much, Marie-Pierre. May I just, before you go ahead, I just want to explain to the audience what exactly we intend to cover during today's webinar. As Marie-Pierre mentioned, one of the key factors I want to discuss today isn't so much about the imaging findings in patients with COVID pneumonia, which we have covered in depth in the last two webinars, but I want to focus on how departments actually manage their resources and demand during this emergency. So there are two aspects to that. One is, what steps do you put in place to ensure the safe throughput of patients who may be infected and those who are not infected, and to protect staff and to protect patients from one another in these circumstances. And the second aspect that I've asked each of today's speakers to address is how they manage other work, non-COVID related work, during this time when virtually all of our attention is focused on COVID patients. So other illness doesn't stop. People will continue to need our services for other conditions that are not related to coronavirus infection. What I've asked the speakers to focus on in the second part of what each of them will be saying is, how do you decide what work needs to be done? How do you triage patients? What work are you continuing to do as normal during this period? Each of our two speakers, Marie-Pierre Revel from Paris and Marcelo Sanchez from Barcelona, will speak in turn about these aspects of their own departmental work. So we'll go back to Marie-Pierre, please.
So I will briefly present myself. So I'm a chest radiologist working in Paris at Cochin Hospital. This is here, Cochin in the southern part of Paris. And Cochin Hospital is part of a group of 5 university hospitals, and in total we had around 500 COVID patients. So I try to explain the practical equipment issues, and to face this epidemic, I think that we can summarize our objectives with 2 main objectives. First one is to be as efficient as possible, and the second objective is to minimize cross-contamination risk for non-COVID patients and for the staff. So what did we do at Cochin Hospital? And what was our recent situation? You will see that my colleague from Spain, Marcelo Sanchez, is facing more cases. We have around 100 hospitalized COVID patients, nearly 70 in ICU, and what has changed is that the number of ICU beds has been tripled in our hospital gradually, not suddenly, but from days to days, weeks to weeks since the epidemic, we had to increase the number of ICU beds. Next slide, please. And so this increase of ICU beds had important consequences on our activity, with a major increase of the number of bedside chest X-ray. These patients in ICUs are very unstable. It's not possible to send them to the CT unit. So by default, our colleagues use chest X-ray. And first, we had to really optimize their prescription to explain that it's only for ICU patients. Other patients, like in a normal hospitalization system, if they need an imaging modality, they should be sent for CT. But for ICU, we had to talk with our physician colleagues to optimize the prescription to avoid bedside chest X-ray to be systematically prescribed, and just because it's not an imaging modality which is really contributive. It's useful when they suspect a superinfection, but there are clinical signs for it, like a lot of secretions, for instance, or some complications. And regarding the detection of pneumothorax, they mainly use ultrasound. So talking with our colleagues allowed to reduce the number of chest X-ray. As you can see, during the last weekend, we only performed 63 bedside chest X-ray as compared to 150 the previous week. We have dedicated mobile X-ray machines located in each ICU. And it's important to optimize the number because the time required is multiplied by a factor of 2 or 3 as compared to normal situations, because it takes around 20 minutes per chest X-ray, which represent the time to dress, to acquire, to undress, and to develop. And we had to affect more technologists to this task. We had to double the number of technologists affected to this task. And we organized that they would go to each ICU at fixed times, 2 times a day. And for instance, if there's a catheter replacement and a patient needing another chest X-ray, rather than asking the technologists to come immediately, they know that they will be again in the ICU at 4 p.m., for instance. So it really helped the situation. Otherwise, the risk was that our technologies would be really exhausted. I have to mention that there's a geographic specificity of our hospital. It's not a unique building, it's different buildings, and they would have to run from buildings to the different ICUs, because we have currently 6 different ICU units. So this is one of the points I wanted to highlight. Next slide, please. And regarding CT, it's much more easier. We have one dedicated CT equipment close to the emergency room, which is dedicated to the evaluation of COVID patients, either those who are suspected or those who have a confirmed COVID disease, but who present clinical deterioration. And this is very helpful because we avoid mixing different categories of patients. It allows to concentrate the protective equipment to a single location. And we have a dedicated phone line. And the idea is that there should be no waiting time before, after the CT acquisition, with an accompanying staff who will wait until the CT examination is completed. We recommend that there's only one technologist in the room close to the patient, and we have a reasonable activity. It's very manageable. In our emergency room, they only see 90 patients per day, and from these patients, only those with respiratory symptoms, desaturation, dyspnea are sent for CT. And very severe patients, they are hospitalized anyway, and when they are unstable, they don't have a CT examination. The reason why we have so few patients presented at the emergency room is that in France, we really wanted that patients with few symptoms stay home. to respect the lockdown. And we have some apps like Covidom, and also a dedicated website, maladicoronavirus.fr, allowing self-surveillance and providing advices for patients who are not hospitalized. So since the diagnosis is suspected or confirmed, the patient and he or her general practitioner register to this app, Covidom, and this allows phone surveillance, also self-reporting, and patients can obtain some advice on the app 24 hours, 7 days, all the time. The last thing I want to say is that we, because of a specific geography with part of the buildings on the other side of a street with no CT equipment there, we had to develop an ICU there. We requested a special authorization to use the CT unit of the PET CT equipment that was close to this place. I don't know if you still hear me. Can you hear me?
Sorry, I just had to pull a blind. Yes, I can hear you.
Okay, so
Please go ahead. Yeah.
I will. Okay, so what I wanted to explain is that we asked for special permission, the authorization to use the CT unit of the PET CT equipment that was across the street to avoid that ICU patients from the ICU, which was located at the other side of the street, had to take an ambulance to go for a CT. And this equipment is used for COVID and non-COVID patients, for emergencies, of course. And so we had to explain how to proceed. We have a dedicated phone line. We explain the technologies from the nuclear medicine department, how to perform the CT, and then we perform the interpretation. So yesterday we evaluated a patient with a CT pulmonary angiography, which allowed diagnosing a pulmonary embolism. May I have the next slide, please? So another important point is to maintain radiology services from non-COVID patients, and we have two priorities. One is oncology. Cancer does not stop during the epidemic. And we have also to manage the other emergencies. So we do that activity on other CT units. And to perform a selection, we ask two of our fellows to systematically read the radiological examination request forms for the coming week. And they would keep all CT examinations related to and MR related to initial staging, follow-up under medical treatment, chemo, but also targeted therapies, and all suspicions of recurrence. But systematic evaluation after remission is the kind of examination that we decided to postpone. Regarding interventional radiology, we kept all procedures related to oncology. What you can see here on the slide is a biopsy I performed last Wednesday on a lung transplant recipient, a young girl with a unique lung who was suspected of having a lymphoma. And we have a dedicated phone line for emergencies other than COVID. We thought it's very important to facilitate communication. So rather than sending a form, prescribing with the internet apps, phone calls, dedicated line with one radiologist available for emergencies non-related to COVID, another for all COVID emergencies, and this really helps. May I have the next slide, please? Regarding staff organization, we chose to have remote working for secretaries, but also for part of the radiologists. They can connect to the PAC system from their home. Of course, we need to have at least one senior radiologist per CT equipment and per MR equipment. And this was a choice in order to limit the number of persons on site. I have to say that all connections were activated very rapidly. A procedure was sent to all staff members, and those who were facing some difficulties, the IT department of our hospital was very reactive and was helping them. Lastly, regarding the MDT the multidisciplinary meetings, they are maintained with two modes of organization, either online meeting. This is, for instance, the case for the internal medicine department. They provide us a list of patients requiring that we analyze their different imaging with a special question. And we kept face-to-face meeting for thoracic oncology and general oncology, but with only one representative for each subspecialty in order to minimize the number of persons in the room, like one pathologist only, one radiologist only, etc., and with 1 meter distance between each participant. Next slide, please. Last thing I want to say is that communication is very important. We have online crisis meeting on a daily basis, but only chief of department attend this online meeting. So every day I send an email to all members of the staff to keep them informed about the last decisions. And it's very important to have an ability to adapt daily to the situation. And this is what we've been doing these last weeks. I would say that there's a lot of solidarity between colleagues. Everybody is trying to help, and especially as a matter of example, what I said about our problem with the number of the increased number of bedside chest X-ray, they really helped solving that problem. And last thing, we have a daily update about the main publications with summaries which are provided by the central research team of our hospitals, and it's very helpful. Everybody is very busy. We don't have time to go through PubMed and read tons of articles. So these summaries, especially in topics which are not radiology, they are really, really helpful because it is a new disease, and the more we know about it, the best we are. Thank you very much.
I think will be helpful to other departments. Now we're going to move on to our third speaker of this webinar, Professor Marcelo Sanchez from Barcelona, who's going to tell us what's happening in his hospital. Marcelo, I'll hand over to you.
Okay. Good afternoon. I am Marcelo Sanchez, Head of Thoracic Radiology at Hospital Clinic in Barcelona and Associate Professor at the University of Barcelona. I would like, next slide please. I would like to show an overview of the situation in my hospital, similar to other hospitals in Spain. As you see, the red line is the number of COVID inpatients in our hospital. This number increased quickly, and these numbers are from 13th to 30th of May. And now today, the hospital has 945 inpatients in different facilities, as ICU, hospital wards, a medicalized hotel, and home hospitalization. Next slide. We can see in this chart the increasing number of ICU patients. Today, there are 98 patients in ICU and 25 patients in intermediate care. Our hospital has also a special geography, and we have 12 ICU units. Next slide, please. I'll start discussing equipment issues. Next, please. We manage COVID patients mainly with chest X-ray, and all the chest X-ray in COVID patients are performed with mobile equipment at the bedside. Due to this, 3 new mobile X-ray equipment were acquired to cover this increase of number of X-rays and additional sites as the hospitalized hotel I mentioned before. We have to increase the number of technologists performing mobile X-rays and the number of radiologists from different sections reporting X-rays. Now, in my hospital, radiologists from all the sections are reporting chest X-ray. In the same way, in the inpatient COVID-19, we try that all ultrasound studies are performed with mobile equipment at the bedside. Next, please. We have allocated specific equipment only for COVID patients. We have a specific CT, and a specific MRI, and a specific ultrasound box. And we have also a specific X-ray equipment for COVID-19 outpatients, patients that come from primary care and home hospitalization. Next slide, please. Here in the chart on the left, we see the increase in the number of portable radiographs, similar to the increase in hospital beds, with maximums up to 180 X-ray per day. In the right chart, we see the number of non-portable chest X-ray, mainly coming from emergency department. We had maximums near 180 X-ray, but this number are decreasing in the last days. Next one, please. Thoracic CT in our center is performed in these patients with 3 main indications: with clinical suspicion with negative PCR and inconclusive or negative X-ray, to evaluate patients with torpid course of the disease, to torpid and long course of the disease, to assess fibrosis and steroid treatment, and the third indication is to rule out pulmonary embolism. Next one, please. We also perform CT in cases of urgent surgery that cannot be delayed, and PCR is not available. If surgery can be delayed, PCR and X-ray are performed. Next one, please. In this chart, we see the increased number of chest CT and CT pulmonary angiography, especially in the last week, as the number of hospitalized patients and days of hospital stay increases. Next, please. And about PE, I'd like to highlight the high incidence of PE in our center. In the first 100 CT angiograms, we have an incidence of 30% of PE in these patients. Next, please. And now I'll talk about workload. Next, please. How do we manage the workload in this situation? Next, please. We have reduced our schedule activity by 70 to 80%, depending on the area. We have postponed the schedule studies until April the 30th, and we'll see if we have to go further. To do this, all requests are reviewed to decide if they are maintained or with what priority they are rescheduled. We rank requests on a 3-grade priority scale. Priority 1 is reschedule quickly. Priority 3 is that we can wait to reschedule. Much of the service is working remotely, and all the multidisciplinary meetings are remote meetings in our center. Next, please. And what patients do we keep in the schedule? What patients do we maintain? We keep oncologic patients in active treatment or in staging to decide treatment. We also maintain non-delayable studies based on clinical criteria, as some infections, as tuberculosis or as aspergillosis. In all the studies kept, it's important to take a quick look at the lungs to detect unexpected or incidental cases of COVID as soon as possible. We maintain emergency service and international procedures that cannot be delayed. We have seen decrease in the emergency department of non-COVID patients, including trauma patients, stroke patients, and cardiac patients. Finally, we'll talk about personnel and protection. Next, please. Next slide, please. We do in our department personal segregation to minimize risk of disease transmission. We have created 4 independent separate groups to cover the emergency service. We have increased the staff in emergency service from 3 to 4 radiologists on site, 3 of them residents, and 2 radiologists at home reporting X-ray. In each section of our department, there is a radiologist working on site per day, and the rest of the staff is working at home. In vascular interventional, we have created segregated groups of radiologists and nurses to avoid contact and contamination. So if one group becomes contaminated, the other group can carry out its functions. Next one. We do not only segregate radiologists, we segregate technologists and nurses for each one of the modalities, CT, MRIs, ultrasound, with a weekly rotation. Next, please. And finally, I'll talk about protection. These are the general protection measures that all we know and are similar in all hospitals. This is the chart from my hospital. Next slide, please. Next. I'd like to remark some specific measures that I think that are important, like that all patients in the radiology department should wear a mask. Technologists should wear a surgical or FFP2 mask for all procedures. The CT equipment used for non-COVID patients is cleaned every hour with sodium hypochlorite solution. The CT equipment for COVID patients is cleaned after each patient. And in stroke patients, for treatments in the interventional suite, we consider all patients as COVID in terms of personal protection. And that's all. I hope that all this information could be useful for the audience. Thank you very much.
Thank you very much, Marcelo. Again, this is experience from a second high volume center dealing with a lot of sick patients, and it's very valuable to our listeners. Thank you for sharing all that with us. The questions are coming in thick and fast. We've had a number about ultrasound use in the chest. One I see from Mexico City, and you're very welcome, and thank you for joining us. We dealt with that in the first broadcast of this series of 4 when we first spoke to Professor Nicola Sferzolati from Parma. So rather than go into that again today, I'd suggest perhaps you might want to look at that broadcast. One question that has come repeatedly from a number of watchers, viewers today, and which has been touched on by Professor Sanchez, is the issue of pulmonary embolic disease in COVID positive patients. And we discussed this prior to beginning the broadcast, and both of you, I think, have comments to make about this and have gained experience with it. So perhaps I might go to you first on that, Marie-Pierre.
Yes, this is a very relevant question. So we just evaluated the prevalence of pulmonary embolism during in the patient that we evaluated in March. So from roughly 900 CT examination, 10%, 91 were performed with a PE protocol for 2 different reasons. For some patients at initial presentation, there was an hesitation between COVID disease or PE when these patients presented at the emergency room with shortness of breath or chest pain. So this is approximately half the CTPA that we performed. And the second request was patients already hospitalized with a confirmed COVID pneumonia who presented clinical deterioration. And based on this 91 CTPA performed, we found 24% prevalence of pulmonary embolism, and we analyzed if there were some differences between the P positive group and the P negative group. And what we found was that patients with P had marked increase of D-dimer level. The mean values were very different, around 6,000 for 6,000 microgram per liter in the P positive group, and around 2,000 microgram per liter in the P positive negative group. And other differences were that patients with P were significantly older and they were more frequently ventilated. Very interestingly, we did not find differences regarding lung disease extent on CT between these 2 patient groups. So I have to say we submitted a paper. We will see what happens, but we communicated this information to our colleagues from the intensive care unit, from the emergency department, and what we decided is to more largely use contrast when performing a CT in a COVID patient, especially if the D-dimer level is very high. And if the renal function allows it. So 24% prevalence and very high level of D-dimer. This is my report about that question.
Thank you very much, Marie-Pierre. Marcelo, may I come back to you about this? You reported a 30% positivity rate among those in whom you've done CTPAs. So I think your experience has been quite similar. Are there any particular reasons why we should be slow to use contrast in patients with COVID pneumonia? Or should we be doing CTPAs on many more of these patients?
For us, pulmonary embolism didn't exist 2 weeks ago, more or less. We did one CT angiography, but I think that with the increase of the number of hospitalized patients and with increase with the number of patients in ICU and of days of stay in the hospital, we have seen an important increase in pulmonary embolism. And now at the beginning, we perform all the CT without contrast. And now if the D-dimer is higher than 3,000, we usually to use contrast with these patients. We don't know if we are now trying to study if this pulmonary embolism come from thrombus in the extremities or are due to local phenomena in the lung, or is for local causes in the lung and not for migration of thrombus. We don't know, because I think that all of this is new. There is no literature, there are no papers about the pulmonary embolism in COVID patients, and maybe we are changing our protocol or our idea to manage these patients every week.
Thank you. Yes, it's interesting that you both have the same experience, and it may well be that these patients have an especially high incidence of pulmonary embolism. It's certainly something we all need to watch for. I note one question that's just come in asking about the possibility of doing ventilation scintigraphy in COVID patients. I would imagine that that would be an aerosolizing procedure and probably quite dangerous in terms of transmission of infection to staff and to other patients. So in general, I would imagine we would be better avoiding using ventilation scintigraphy, if at all possible, in making this diagnosis. We've also had a couple of other questions about equipment. One has asked about how do you deal with segregating patients if you've only got one CT scanner? And a second question that in some way is allied to that asks, how do you provide equipment to radiologists reporting from home, or what equipment is required in terms of standard of monitors? I think they're both questions relate to resources, and I would imagine that this depends very much on how well resourced a facility you have. Do either of you have any comments? Marcelo, please go ahead.
Yes, about the CT, I don't know, because we have 3 CTs and one is dedicated to COVID patients and the other two non-COVID patients. This was till last week, and now we have changed. We have 2 CT for COVID patients and 1 CT for non-COVID. And these equipments are separated, are not near one from the other. About reporting at home, at my department, we used to work at home at least 1 day a week, and almost every radiologist in my department has an equipment at home to report studies. The thing is that these equipments are better for report CT or MRI, because to report chest X-ray you need more resolution in the screen and more resolution in the system. These days are COVID days, and we have allowed to report chest X-ray with the equipment that everybody has at home, and we don't require a ultra high resolution screen that outside the COVID outbreak, maybe to report chest X-ray at home, it would be desirable.
I think that's a pragmatic answer. In effect, make the best you can of the equipment you've got available. You're not probably going to be able to bring a new CT scanner into service very rapidly, unless you do something like you have done in Paris, Marie-Pierre, by utilizing a PET CT scanner. And that's an interesting innovation. May I come to you, Marie-Pierre, for another, beg your pardon, go ahead.
No, I just wanted to mention that at first, at the beginning of the epidemic, it was not needed that we dedicate the CT the whole day to the evaluation of COVID. what we discussed with our colleague of the emergency room was to use that dedicated phone line and try, if possible, to ask for CT at dedicated hours so that we should not mix non-COVID and COVID patients. But very rapidly, we dedicated the whole CT unit. Coming back to that organization with the nuclear medicine department, they still perform PET CT for oncologic reasons on the morning. So we saved a slot very early in the morning before they start the activity, if there is something very urgent during the night, to be not in order to avoid waiting until 3 p.m., which is the time where we stop the nuclear medicine activity and we start for emergencies, CT emergencies for COVID patients.
Thank you. May I ask you one more question, Marie-Pierre? It's one that's come in from a viewer. Have any of you seen intrapulmonary abscesses in these patients?
No, I haven't. I haven't seen any abscesses. No. Really, it's mainly ground glass transforming into organizing pneumonia patterns. Pleural effusion are extremely rare. There are no adenopathies, and if there is a consolidation, a focal consolidation, we should suspect superinfection. And a very useful sign for superinfection is the presence of impactions within the bronchial lumen. In the COVID pneumonia, there is no secretion unless there is a superinfection, but no abscesses.
So mucus plugging is a very useful sign then in identifying bacterial superinfection. Thank you.
Yes.
Marcelo, have you seen pulmonary abscess? I would imagine it takes so long for those to develop that the timescale has been too short for that.
I have not seen any abscess, and I think that we'll see an abscess in a patient, and we suggest superinfection, and it was a bacterial. It was a bacterial infection. The abscess was not COVID. We have seen great big pulmonary infarctions in some patients related to the pulmonary embolism. This thing we have seen, but not abscesses.
Thank you. At this stage, I'm going to.
It's true that.
Please.
Sorry. No,
Go
it's
ahead,
true that
please.
this immune reaction, which is excessive, is also associated with a hypercoagulable state. And coming back again to this evaluation that we performed, it's important to mention that this PE did not occur, especially in patients that were hospitalized for several days. So it was not being not moving in an ICU bed, which was the reason. It's really this increase of coagulability due to the severity of the disease, which is probably the cause. And the reason why half of the Ps we saw were at first admission, not especially in ICU patients after 1 week hospitalization.
So have a low index of suspicion for the possibility of pulmonary embolism in these patients because they are hypercoagulable. At this stage, I'm going to go back to Dr. Abdel-Wahab for some closing comments. Dr. Abdel-Wahab.
Can you hear me? Thank you very much.
Yes, we can.
I think the one thing that's pretty obvious is that we need to be flexible in terms of how we set up our departments and the flow of patients. Because when you start out with a small number of COVID-19 patients, you may be able to choose a specific machine for those and separate them. But as we go forward and we have a larger number of patients, we'll need to modify. So I think the main thing is how to be flexible and to be very agile in terms of addressing the needs within the departments. The other thing is the supply chain. We have to be very careful about making sure that we have the supplies that we need. And there are many activities that are being done on the IAEA level and the WHO level to see how we can help that. But this has been a very exciting discussion, and every day there are new things that come up, and we're very glad to have our experts with us. I also want to congratulate ESR and also ISR for this thing, and thank you, Adrian, for moderating, and of course Stephanie and Monica for helping with this. I think Dr. Donoso and Dr. Bariacic, supported this, and you guys are really, as usual, very busy with trying to make the clinic ends meet. So we thank you very much for all this wonderful interventions that you're describing right now. So thank you, Adrian.
Thank you very much, May, and we're very grateful for the co-sponsorship of this ESR Connect event by the IAEA. I'm very happy to work with you on this. I'd also like to thank Marie-Pierre Revel and Marcelo Sanchez for giving us of your time and expertise today. What you've had to say has been really instructive and helpful. You're both working in countries that, along with Italy, are the hardest hit in Europe in terms of numbers of cases. And therefore, you've accumulated a lot of experience very rapidly, and it's very helpful to the rest of us to be able to lean on that experience and learn from it. Apologies to those of you viewing this event who have not had your questions dealt with directly. Some of them ask questions about things we've already covered in episodes 1 and 2. Those episodes are available on the ESR YouTube channel, and I would recommend that you go back and look at those. Some of the questions you've asked today may be answered there. And we will be back again next week with another episode focusing on some different aspects of this pandemic from the radiology point of view, which may further elucidate some of the issues that you want us to cover. So with that, we'll close for this evening, and I'd like to thank everybody for participating and for watching. We hope this has been useful to you. Thank you all very much. Bye-bye.
Thank you. Bye-bye.